And Dr. Roten donated many of his slides to the Cambridge Lectures in Neurosurgical Anatomy, and I'll be using many of them in the audience. But I also, particularly because of the topic, lateral ventricles and approaches, I need to mention Ramesh, who is sitting in the audience, and it's a great pleasure to have him around. And I've learned a lot from him, and lots of his wisdom I'll be sharing here. And also Professor Guilherme Ribas, who has been a great friend and from whom I've learned a great deal over the years. And it's really coming from him that is really sort of part of my subconsciousness, that lateral ventricles are C-shaped. Sort of, you can see the shape, C-shape, and they're C-shaped because they're rotating around the central core, specifically around the thalamus. And this is indeed a prosection that Dr. Ribas has shown many times. And to understand brain properly, the operating brain properly, we ought to understand the brain as it has developed over phylogenesis, which is really reproduced to an extent in ontogenesis of every individual person. It's really an outpouch of the diencephalon, that the diencephalon arises, and the foramen of Monro pretty much is the entry into the lateral ventricles that starts as a small pouch around the foramen of Monro, then elongates anteriorly and rotates around the thalamus posteriorly and inferiorly, and really this is kind of the semi-end product of the rotation. And again, rotation around the thalamus. So, for example, you can see on this picture or transection of the embryological situation that the structures that initially start superiorly rotate around the thalamus and end up inferiorly in the temple area, but because they are on the thalamus, they will be stuck to thalamus. So, for example, you can see that's the origin. That was the head of caudate, but in the rotation, that's where the caudate started, and you can imagine how it was dragged around the thalamus, which is not here. That's the hole here, or the thalamus dragged around posteriorly, and the body of the caudate is thinner than the head, and the tail of the caudate is very thin, and because it's stuck to thalamus, it is on the sort of lateral wall here, you could say nearly floor. At the frontal horn and body of the thalamus, but it is in the roof on the temporal horn, because everything is inverted. And of course, this is amygdala in the anterior roof of the temporal horn. And here is the actual ventricle. So on the floor of the temporal horn is the hippocampus, and on the roof is amygdala, and the continuation of the amygdala really with the caudate nucleus, either tail of the caudate. And this is important to keep this in mind. Now, as the ventricle rotates around posterior laterally, the foramen of Monro, you could say, also rotates posterior laterally in a way, because there is a gap between the between the thalamus and the lateral structure, which is the fornix. And again, the fornix starts as a fimbria of the fornices on the surface of the hippocampus, and then forms crurround body, and eventually separates into two columns. So between the thalamus and the fornix, there is no real gap. It is covered by a curtain called tila choroidea. And the tila choroidea has two holes, which is the foramen of Monro superiorly, or the superior choroid point and the inferior choroid point through which anterior choroidal artery enters the temporal horn. And we can really open the gap if we need to, or sometimes certain tumors and lesions do. So there can be sort of a seamless transition between, let's say, the ambient cistern and temporal horn, or tectal cistern and temporal horn, atrium, etc. You can see the choroid plexus filling the gap between the fornix and hippocampus on one end, and the thalamus and caudate at the other end. And it's also important to be clear about some basic principles, and one of them is that the blood supply to the brain comes from PL structures, and pia is really what brings vessels into it. And when pia and ependyma attach together, they form choroid plexus. And really what the choroid plexus, or the really is a curtain that is made of two layers. On the ventricular side, it's the ependyma, and on the outside of the brain side, it is the pia. And here we have it again, foramen and Monroe, choroid plexus stretched between the fornix, which is on the outside circle, and thalamus, which is the inside circle. And I won't be dwelling about it too much. Just want to highlight that the choroid plexus has a rich blood supply from a number of arteries. They're also kind of called choroidal artery, but we won't be going into details of it. But it's important, particularly when dealing with tumors that derive blood supply from it, because it's not just one artery going into it. It's a bit of like a circle of Willis that is being supplied from a number of branches. You have anterior choroidal, medial posterior choroidal, then you have lateral choroidal, and so on, lots of lateral choroidal arteries, etc. For example, the medial posterior choroidal artery, that of course is in the velum interpositum, which is the roof of the third ventricle, and then we'll talk about the fourth ventricles today, but it is relevant to fourth ventricular surgery. Also, what perhaps say on this slide, that the structure that is stretched between corpus callosum and fornix, septum pellucidum, there's a brain tissue, a functional brain tissue devoid structure, and it can be penetrated, used without any problems. But what we need to be aware is that it is not always as broad as it is on this picture, because sometimes lots of people, particularly with no hydrocephalus and no major atrophy, the corpus callosum and the fornix can be very close together. This is kind of pretty much an average, a normal person's scan. Again, fornix here going just posterior to the anterior commissure, and that's of course, corpus callosum, and in between is the septum pellucidum. So we need to be really careful when we do septum pellucidotomy or operate on tumors that arise from the septum pellucidum, because of course fornix in particular is in danger. And Dr. Roten and so the school were very systematic about how they went about anatomy. So I'll at least today follow the suit. So the lateral ventricles have body, they have anterior, temporal, and occipital horns, and atrium. The frontal horn has walls, and is a medial wall, which is the septum pellucidum, and somewhat the fornices. Laterally, a lateral wall is a caudate nucleus, and floor is the rostrum of the corpus callosum, and roof and anterior wall is genu. This was a little bit of a schematic picture. This is a cadaver, and again we see the septum pellucidum in the middle, then partially the fornix, which then blends into floor, and the floor extends into rostrum, and you can see the caudate nucleus. because we know that this is the thalamus striate sulcus between the thalamus, of course, here, and striatum, which is the part of the striatum called caudate nucleus here. And that's kind of a zoom out version of the same thing. And so we won't be going through it very much. It's just showing the fairly angled position of the columns rather than vertical as we sometimes imagine it is. This is a picture from Dr. Sikla's paper, which kind of is one of the good, nice pictures how to access kind of schematically various parts of the body, and you can see that you can access the frontal horn, either frontal transcortical or interhemispheric transcallosal. That these are the two principal approaches, and I won't be going through it, but essentially we have veins, and then we go between the dura and medially, and so on down through the corpus callosum, and we then end up in the ventricle of choice. Now, when talking about the transcallosal approaches, I'd like to sort of highlight the importance of corpus callosum, because we always think, where the callosotomy should be and what's going to happen if we perform callosotomy and so on. This is quite a useful review paper by Dr. Gia from Dr. Ratka's team, and I'll return to it a little bit later on. Essentially, these colors represent commissure fibers that correspond to various functional parts of the brain. So in this paper, they sort of list various problems that can happen, and you'll be familiar, particularly with various disconnection syndromes, including SMA syndrome, alien hand syndrome, and sort of discoordination of ability to listen with left and right eye separately. It's similar to alien hand syndrome, and so on. I won't really have time to go through it, but I'd like to refer you to this paper. Now, the most important part of it is that all this information is derived pretty much from epilepsy papers, and as such, it's compounded by lots of dysfunctional brains that, of course, patients with epilepsy will have. So the information on the topic is very rudimentary. This table doesn't mention memory, but memory is an important part of the component, although one always has to question how much the memory might have been impaired by potential damage to fornix, either directly or vascular, and so on. I'd like to again refer to Guillermo Ribas and his picture that he keeps sort of painting to us by his words, but I thought I'll give you a little illustration here. Is that corpus callosum, albeit is narrow in the middle, is like the body of a butterfly. The corpus callosum then continues into the hemispheres, as if you imagine sort of butterfly spreading his wings and flapping his wings up and down. So the corpus callosum continues into the hemisphere, but furthermore, it is really complicated network of various long association fibers, not just commissural fibers. So when we go through any part of the brain, we have to be very much mindful of that. So if we, this is a carcinoma of the caudate, very straightforward approach to it, but particularly in the anterior part of the ventricular system, in the frontal horn, it is actually really complicated in that you can have a number of lesions. This one is pilomyxoid astrocytoma, for example. This one, I deliberately don't put it here. You can think in your heads what it could be. This is, before and after. And you can see that the fornix is always fornix is to me the ultimate thing to preserve, and it's sometimes going to be very difficult, particularly when it is not so obvious preoperatively, despite of the fact that you may do DTI tractography and so on. You may not be able to identify where the fornix is. So you have to be lots of strategies how to early identify the fornix and preserve it. Now, I won't be going through the details of it because this is way beyond the scope of the talk. So this was initially thought to be ganglioglioma, but eventually was diagnosed as SIGA using particularly molecular classification. Another case, now this one you can see that is a bit fuzzy, and it has what we call Dr. Unto no sign, means probably not indicated to operate, but nevertheless I operated and actually worked fine, but didn't get great deal. The person improved after the surgery, lived for still lives actually a number of years, but it's got pretty bad diagnosis. I'm deliberately showing the various things because they come in various forms and shapes, and really the key preservation is fornix. For example, here, very difficult to know where the fornix is, but again, we're very careful and preserved the fornixes, because if we damage a fornix, particularly in a young person, this one is 7-year-old, this one 20-year-old student from our local university, as you can see, with various hydrocephalus, but also memory problems. So I usually go to absolute greatest extent to preserve the fornix. So you can see the two fornices preserved. Central neurocytoma. Anyway, going to body. Now, the definition of body is between the posterior aspect of foramina Monroe to where the fornix joins corpus callosum. So again, it is various lengths in different people. And again, the boundaries of the body are thalamus, caudate, corpus callosum, and septum pellucidum, and of course fornix medially. And the approaches can be interfornicial, and I won't be going through it, but perhaps you use this picture here, for those who kind of starting to operate, and this is without any lesion in it. And you can see how sometimes it's difficult to say where the septum pellucidum starts and where the fornix finishes. Sometimes it's obvious, sometimes it's not. And of course, if we start making a hole in the septum pellucidum or removing a tumor and get carried away, we can damage the fornix, and particularly in a relatively benign lesion in a young person, we can cause a lot of damage. So we have to be really careful and clear in our head what the priorities of each surgery are. So we skip through that, and how we access body. Well, body is a bit tricky, but essentially we can go frontal transcortical or interhemispheric transcallosal, but the consideration in interhemispheric transcallosal are a bit more complex, because it really depends on the angle at which we need to access the lesion. If we go from anterior, there are usually less veins. If we go so straight directly, it is much more problematic, not only because of the corpus callosum functions, as we discussed, but particularly around here, we have various more important left to right commissural fibers. Also, the veins are usually thicker, more constant. Excuse me. And if any significant venous compromise happened around the paracentral lobule area, and the consequences could be very severe, particularly if the venous congestion translated into hemorrhagic venous infarct. So again, this is all Dr. Roton's and his group's picture. Okay, so I will skip this particular case. Just a word of caution. You know, I've operated lots of metastasis in thalamus, and you could say this is kind of a ventricular sort of issue, like this one, for example. The access to it is one thing, but also the morbidity to consider in tumor like this is of course related to the thalamus itself, but also we must not forget that although we operate on the lateral ventricle, the wall of this case, and this is actually a postoperative picture, there's a bit of blood here, but there's deliberately tumor left here because it was firm and absolutely stuck to both fornix and vessels, as you can see on the T2 picture here, that are in the velum interpositum of the third ventricle. So we were really risking damaging either the internal cerebral vein here directly, but also potentially avulsing internal cerebral vein from vein of Galen, etc. Then of course, you know, this is just to illustrate the various sizes and shapes of the tumor. Again, I gave you a bit of time to think what it might be, and you know there's a central neurocytoma, and it poses completely different issues. So this sort of tumor we need to approach not just from up here, but a little bit more horizontal, because it, as you can see, is
over time.
Over time. Okay. So I will quickly move on to the just very end, and I'd like to not finish without it, is that risks. A risk comes from not knowing what you're doing. It's very plain, very simple, and the whole work of Dr. Roton was to dispel ignorance. And of course, he was a very humble person, and often it is the case that arrogance comes with ignorance, but at the same time, in humbleness comes with great knowledge. And he was certainly a man like this, and it is brilliant that WFNS Anatomical Committee decided to dedicate this section to him, and I was delighted to be able to contribute to it, albeit in a small way. Thank you very much.